Tēnā koutou katoa, talofa lava, warm Pacifica greetings to you all. I'd like to acknowledge the Tainui people who are hosting us here today. I'd like to start with a big thank you to Professor Errol and the Goodfellow unit for this opportunity to contribute to a change for the better, supporting gender diversity in primary care. My fellow presenters are change makers, and I'm humbled to be presenting alongside them. Jo McDonald has a Master's in Gender Studies, Sociology and Social Work. Jo works in mental health at Affinity Services on the Rainbow team as an educator and advocate, increasing access to high-quality health services for all transgender, non-binary and gender non-conforming people. Jeannie Oliphant started as a GP. She worked in Whakatane for 10 years. She then followed her special interest and has been a sexual health physician since 2013, working at Auckland Sexual Health Service, the Auckland Regional Adult Sexual Assault Service, and the Centre for Youth Health in counties, Manukau, providing care for transgender young people. In November, Jeannie was appointed to the clinical lead to lead the development of the Auckland Regional Transgender Health Services. We would also like to introduce you to the Auckland Regional Transgender Health Project Manager, Duncan Matthews, if you could give a wave to people, please, who previously led Rainbow Youth. My name is Fiona Bell. I'm a GP. I've worked in South Seas in Otara since 2000, where I developed an interest in youth health through their community-minded partnership with Otahu College. This has led to my role in Youth Health Services Alliance as the lead GP for ADHB and all the PHOs. We invite you now to be part of the change that will make our world a safer and happier and healthier place. Next slide, please. Oh, you've got the power. I've got the power. That's our conflict of interest slide. And this is just an overview of how we'll cover various questions that I often get asked by other GPs. And I'll hand over to Joey.
Thanks, Fiona. Thanks, Jeannie. Thanks for having me here. I was really pleased that we could negotiate to have a transgender person, a non-binary person alongside health professionals in this area, because I know that we also had an amazing panel that wasn't recorded, but an amazing panel of consumers or people using health services who might also be trans or gender diverse. And that was a really wonderful panel, but it's so great not to separate out all the time into you're either a community member and a consumer or you're a health provider, right? To actually realize there's lots of people who are occupying both of those realms, or, you know, to mix it up. So thanks, I appreciate that. We're trying to do this in quite a short period of time, so I'm probably going to go quite fast and not be able to get to everything, and maybe that means we'll have more time for questions at the end. So what is gender diversity? The main thing I want to say about gender diversity, because the Statistics New Zealand is talking about putting in the census gender diverse alongside male and female, so I think it's important to talk about this term gender diverse. It's meant to be an umbrella term. It's meant to cover a huge amount of diversity, particularly around somebody's identity. So that's, some people identify as men, as women, as non-binary people. There's so many different words that people might use, and there's lots of glossaries that you can go and find. There are resources like this I'm Local one from Rainbow Youth if you want to learn more about the particular terms. But one of the key things is that gender is not sex. Like, gender and assigned sex are two different things. So there's the assigned sex that you're born, you get assigned something, probably male or female. There's a lot of issues for our intersex community around that, we're going to talk a little bit about that actually. And then there's gender identity, which develops as part of your self-determination, something that you figure out for yourself. And then there's sexuality as well, so that's another layer. And I think that just as a starting point, it's helpful to think about those distinctions as well as those overlaps. In my work in mental health services, I talk to a lot of people in a range of different disciplines who are wanting to signal that they're a safe person to talk to, and also wanting to be told, here is the question you should always ask, or here's how you will get it right, and here's how you will never offend anybody. And of course that's not possible. It's so much about building a relationship with that person, and it's a lot about knowing your own bias, knowing your own assumptions, figuring out how to be reflecting on your own self and your own journey as someone with a sex and a gender and a sexuality. But I will say that there are some direct questions, like how do you identify your gender? I personally think that's a great question to ask. Or what pronouns would you like for me to refer to you with? He, she, they, the options. Those are good direct questions. Less good direct questions would be leaping right in there with like, so what do you look like, biologically, or under your clothes? There's a kind of a sense in which sometimes people think that our anatomy needs to be talked about instead of our gender identity. And of course you want to be talking about the health needs to be able to balance both of those things, right? You want to be referring to us how we identify, using the words about our bodies that we use, which may or may not match up to the terms that you use. And I appreciate that clarity is important, but I think you can get there without the less good invasive questions via the more useful direct questions. We've talked about here names, pronouns, bodily self-determination. I'm also going to show a quick video, so I think that's going to happen next. Sam Orchard made this for DPSN. It's a video blog, and it's about a current conversation that I'm seeing a lot in our health services as well as in our transgender and gender diverse communities, which is about how do we get access to care? Is it through an informed consent model, which doesn't just mean signing a piece of paper, informed consent, but also means a kind of respecting that person as an authority on themselves and on their own experience, and not requiring us to prove it or be tested or kind of go through that can be quite demoralizing process of getting a diagnosis. Some people might be quite happy getting a diagnosis, other people not so much. But instead of doing that for everyone, it would be so great if we had this other more flexible option, which we're calling the informed consent model. And this is a video a little bit about that.
Joe, Mental Health, a DPSN video blog.
My name is Joe, or Joey, and I really love coriander.
Tell us about being transgender.
My primary experience of negotiating with health professionals about my mental illness or my state of being is around my gender and whether I want to access healthcare as part of being transgender. I noticed that while some health professionals were quite competent, a lot of it is really unclear for them about how to do it, and so they do rely on things like the DSM, which is like a whole lot of different diagnoses and conditions and criteria to get those diagnoses. And transgender people are still in there under gender dysphoria. The framework they had was based on that we had to be broken, because that's the medical framework, is that you fix things that are broken or you provide a treatment when there's a problem, which in this case doesn't really work or help.
Are there alternatives?
I think some health professionals really have started to grapple with these issues and are talking more about using an informed consent model, which I really support. For example, something like going on hormones. If you were going to do that through an informed consent model, you wouldn't have to have a diagnosis. You would have a conversation, probably several conversations, about what your life was like, what your support systems look like, and then you would also get a lot of information about the risks and the effects and a time frame, and you'd have understandings about what might be reversible, what might not be reversible. It would be explained to you. You would get a chance to ask questions, and the focus would be much more on whether you understand what the medication is going to do and whether you have realistic expectations about it, and much less on evaluating your identity, or are you really a transgender person, or are you just faking it in some weird way. And I think this really shifts the conversation in a really exciting way, because it means that lots of people who don't fit very limited white Western medical model criteria in the DSM could still use this informed consent model to get access to healthcare that can really positively impact your life.
Will that make things easier?
Narratives that we have about transgender people being trapped in the wrong body is an example, and it's kind of like you're meant to know what your end game is, and according to the medical model it should certainly be conforming to all of the expectations of a white middle class binary gendered person. While for some people that might genuinely be their journey, I think the idea that everyone's supposed to know right at the beginning of a process what the end of the process is going to be like, and they have to say, I'm firmly committed to that, that's absolutely what I want, and to not be allowed to have any sense of flexibility or responsiveness doesn't make sense. That's not how we should be doing healthcare. We should be saying, this is an intervention that we can offer you. How does that sound to you? And then you see what it's like. You take that medication for a while. You see how you feel on it. If you don't like it, you stop. And if you do like it, you keep going. I feel like we keep requiring trans people to have a level of certainty about themselves that we don't require other people to have. It just seems kind of ridiculous. Surely it's more simple to talk about support systems and the risks and effects of a medication than expecting a whole lot of people working in health to grapple with the intense nuances and complexities of people trying to evaluate, are you really a transgender person? That sounds way harder. I don't understand. I don't think people should be doing that. On an ethical level, I don't think they should, but also I think their lives would be easier as health professionals if they weren't doing that.
Thanks, I'm going to be really excited to answer questions about that later, but I think that's probably my time. Yeah? Cool.
Sorry. One of the things about Western culture is that even from birth we like to put people in boxes. And I'd just like to mention intersex here. So intersex is a wide range of natural variations of genitals, gonads, hormonal balance, chromosomal patterns. There's about at least 30 different conditions. And so what happens now is that the paediatrician explains what intersex is to the parent, the hospital notifies the registry contacts mother to confirm. The baby's registered or birth assigned sex is actually determined by the paediatrician. The idea of notifying the hospital after, say, the parent disagrees is so that the hospital can provide more wraparound support for the parent and the child. One of the current situations we have at the moment is that the online birth registration form is still binary. And that's something that I think kind of lets us down as we move forward as a society. But all of this stuff is actually changing. It's like it's all changed since last year, and it keeps needing to change a bit more. So it's really important that as people who are involved with pregnant women care, that we need to be aware that even as GPs, we can stop the genital surgery on intersex children before they are able to give their own fully informed consent. Because binary attitudes by all of our team that just reinforces social pressure to only accept boy or girl. It's really important that when we have somebody who has been assigned intersex at birth, that until the family has named that child, that we just refer to that child as their baby, rather than, is that a boy or a girl? Oh, your daughter. Oh, God, I've cocked it up yet again. Excuse the pun. It's just use the child's name when referring to the child when the name has been assigned, and just keep encouraging unconditional love and acceptance of the newborn within natural sex variations that they have. We need to protect those intersex children and their bodily integrity until they are ready to self-determine their gender expression at an older age. It's really important that this actually includes training our receptionists and our other staff, because what we do say does affect how family cope with this intersex birth assignment. So these actually are my twins. And one of the things that I have found working as a GP is that trying to think what would it be like for the parent. It's like every parent is protective. They do worry, will you treat my child differently? When I dressed my kids in pink, they were treated differently from how they were treated when they would dress them in blue. I know that if one of my children is a female, she is more likely to earn less than her brother. And so in being able to at least imagine what a parent might be worrying about for the future of their children, this is just something that I think is important to consider, even though we may never actually really know what it's like going through that as a lived experience. So when gender diverse people try to access help from primary care, most have had negative experiences. A study here in New Zealand, 2015-16, found that most just wanted to feel welcomed, to feel counted like they really existed, to be included and respected. Unconditional love is like the sun, and even if we are not the parents of them, we as carers need to give aroha through our care. And we need to also encourage that. So every parent hopes for a happy and healthy child. There's a feeling of intense unconditional love when they first hold their baby. Parents fear rejection of their child by others, and they try really hard to protect. A lot of it will be protective, but sometimes they will do things unintentionally that actually might cause harm. Cisgendered parents, like myself, often need help to support their gender-diverse children. Heterosexual parents often need help to support their non-heterosexual youth. This makes sense to us as GPs, but we need to slow down and remind ourselves. Parental dreams, they are parental dreams full stop. Sometimes we need to remind parents of their hope, that intense love that they had, so that their child will thrive and not get caught up on other things. So what if as a clinician you still feel personally, culturally, religiously conflicted? I mean, I know people here in the room, I'm probably preaching to the converted, but what's really sad that I learnt from listening to transgender people in community forums was actually their patient rights weren't being respected by some of our colleagues. So we all need to keep talking about these issues so we can support our colleagues to move forward. We took an oath to be professional. What we do or don't do does make a difference. Please reflect on your own beliefs and encourage your colleagues to. Reflect on experiences and attitudes and how they influence the care that we provide. We need to be courageous, declare we're still learning. Strive to communicate more effectively. And probably the surprise here is that, you know what, our younger colleagues have got this. We should talk to our younger colleagues, and sometimes we might even need to join a different peer group to be able to discuss these issues with fresher eyes. If you yourself or a colleague still feels conflicted, just please refer to somebody else. Yeah, so a bugbear of mine is when the information software systems don't fit what we're trying to do. So that currently, medtech versions that I work with don't distinguish gender from birth sex, so it makes it quite messy trying to tidy up the cancer screening for the future. Yeah, software processes need to fit to change people. Right now, the New Zealand Department of Statistics is leading all the ministries and the software vendors to reflect what are human rights, and as the purchasers of the software, we together need to demand that the software changes faster. So what we need to do will be easier. And there's actually a paper handout both at the door and also online at the Goodfellow Symposium conference page about gender transition in NHI that goes into this more detail. But as was suggested in our earlier workshop with the panel, if the current PIMS version is unable to register both the birth assigned sex and the gender that is self-identified, then create a local code. Find a way of documenting it carefully so that you know who you're talking to when they walk in the door or when your colleague sees them the next time they pop in. Changing NHI self-identified gender is as simple as picking up the telephone while the patient's there and getting the gender changed. People are really responsive, they're well trained at the other end of the phone now, and it's an amazing relief to the patient sitting next to you. I can't believe how happy it's made them just doing that, and now they're being recognised and counted for being who they are. Do all gender diverse people want hormone transition? Well, actually, no, but that's not for us to sort out. All people have the right to access info they need to self-determine, and that information they can gather from the transgender health specialist, so we should facilitate that consultation. Puberty hormone blockers do save lives because they prevent distressing disfigurement, and they also buy time to gain family acceptance where the family is not as open-minded. As GPs, we need to take care not to push gender-affirming hormones and also not to obstruct access to specialist information. So how do I, as a GP, support resilience? Well, we all know humans are social beings and we need another human each who is willing 24/7 to support us. For those of you who aren't from Auckland, this is Lions Rock in Piha, and I think it was the Odyssey House who taught us about every human needing their rock to be there 24/7. Children and young people thrive when they have an adult rock, and that family adult, as they get older, is their self-identified family, but it needs to be somebody they can trust and be on that journey with them. We need to encourage the families to accept them and love them for who they are, but sometimes we need to facilitate these protective relationships, and that's where we can refer to Rainbow Community Support Services. And now I'll hand over to Jeannie.
Thank you, Fiona and Joey. That's just been amazing talks from both of you. So my role really is just to talk a little bit about some of the medical interventions and how, as in primary care, we can support this. Now, I know not everyone's from Auckland, but I just wanted to talk briefly about the services that we do have available in Auckland, just so people do know what's out there. And currently in Auckland, we have 2 services that are providing support for transgender health services. We have Auckland Sexual Health Service, which is a regional service, and that provides support for people aged 18 and older who are seeking hormonal transition or support around gender diversity. So Auckland Sexual Health Service is based in Green Lane Clinical Centre, but they also have clinics in Henderson, Glenfield and Mangere, so do feel free to refer, that they have e-referrals. And then the second service is the Centre for Youth Health, and that's a service that's focused on younger people. So Centre for Youth Health is based in Counties Manukau, DHB, and within the Counties Manukau area they provide a service from an age range really to 12 to 25 and see young people with a whole range of health issues. And we do support lots of people who need support around their gender identity. And more recently, Centre for Youth Health now have the contracts in Waitemata and ADHB to provide support for young people up to the age of 20. So there is a little bit of overlap between the Auckland Sexual Health Service and the Centre for Youth Health. Now this slide, I was just wanting to look a little bit about the whole primary secondary care continuum and what health needs fit where. And, you know, there's flexibility around this, of course, and some GPs will be confident and have a special interest, and some GPs will feel less confident and want to refer earlier, which is absolutely fine. But I think as a starting point, certainly within secondary care services, what we can offer is time with people exploring gender identity and also those wider support, things around supporting families, and around supporting connections and emotional well-being. Now, a lot of that can also be done in primary care as well, obviously. And then in secondary care, what we do a lot is support around puberty blocking and initiation of hormones, fertility preservation, and we have funded sperm storage available in Auckland, and also we're able to manage referrals within other secondary care departments such as voice therapy or gender-affirming surgeries. Within primary care, I mean, I think primary health care obviously sits in primary care, and that's important. Cancer screening traditionally sits in primary care, and I think we need to think a little bit more around cancer screening for gender diverse people. We need to think about the organs that we're screening, whether people still have a prostate or a cervix or breasts, that we should be thinking about offering cancer screening services, and how to do that in a way which is not focusing on as a gender screening, but is focusing on the target organ that we're screening for cancer. I think maintenance of hormone therapy sits really well in primary care. in terms of ongoing prescribing and surveillance for health issues and monitoring for comorbidities and supporting harm minimisation, and then of course having the ability to refer back into secondary care where people are needing support, whether that's a phone call or a face-to-face consultation. I just want to follow on from what Joey said about the conversations that we have, because I think that, I feel quite strongly that informed consent is a process really, and it's not a piece of paper, and it is about having series of conversations with people. It's not kind of like a sign here, here's your script, away you go kind of thing. And certainly in the services in Auckland, that's a lot of what we focus on in terms of helping people who want to self-identify with the gender that they are, and having a shared decision-making, but also being a holistic approach to somebody's health, so a whole of health and well-being that includes both medical and psychological health as well. I think we need to know about GnRH blockers because puberty blockers are the standard of care for transgender young people, and they are very safe, they're very well tolerated, they're fully reversible, so if at any point along the way somebody wanted to stop their puberty blocker, then puberty just kicks in again, and they can certainly be hugely beneficial in relieving psychological distress where people are distressed about changing bodies through adolescence. But they're not just beneficial in really early puberty, because if you think about it, those pubertal changes continue through into your mid-20s. So we're using puberty blockers with young people really up to about the age of 20. And they can alter your life trajectory. And I'm just going to show this photo here, which is a widely circulated photo of identical male twins, assigned sex at birth being male, but the twin on the left started on puberty blockers at about 12 and identifies as female. So you can see that starting on a blocker makes a huge difference to your kind of physical development. Blockers are injections, they're safe, there's no particular drug interactions, there are some things that we need to think about in terms of safely prescribing. And the other thing to note with blockers is that PHARMAC reviewed this category of medications last year, and now currently Zoladex is the only subsidised GnRH blocker, and a lot of you will be familiar with using Zoladex. We're still using Lucrum because it's more acceptable in a younger age group, but you just need to know to endorse the prescription appropriately. And then as part of our processes, we'd like to continue those series of conversations and talk about readiness for hormones. And currently within the teams in Auckland, in terms of Auckland Sexual Health and the Centre for Youth Health, we do involve a range of people to have discussions with young people particularly about reviewing people's strengths and really just seeing how this is going to look for you in terms of starting on hormones and in terms of families and school and work environments and all those other things. There are some precautions to think about when prescribing hormonal treatment, so we do have to think about cerebrovascular disease and arterial and venous thromboembolic concerns, and also hormone-sensitive cancers, migraine, sleep apnea, so there's some just things to think about. And in terms of prescribing maintenance, hormonal treatments, so if we're thinking about the feminising therapies, people usually stay on an anti-androgen agent, whether that's a blocker, although often by the time people are transferring their care back to primary care, they may well be on an oral anti-androgen agent, and in New Zealand most people use cyproterone because that's a more effective anti-androgen, but some people use spiral and lactone. Plus, of course, you need estrogen as well, and the estrogen that we're using is estradiol valerate. There's no place for using ethinyl estradiol because the risks for thrombotic events are so much higher, so Jeanette shouldn't be prescribed, but we're using Proganova. And then in terms of monitoring the prescribing of anti-androgens and estrogen, it's good practice to check blood tests annually, thinking about liver tests, HbA1c, lipids. And in terms of hormonal endpoints, with estradiol levels, we're really just wanting to avoid supraphysiological levels, because really you're titrating doses to what's happening in somebody's body, and it's quite variable between people as to what doses have what effect in terms of breast development. And testosterone, we're just aiming for suppression. Still considered good practice to check prolactin at least every 2 years, because of the small risk of prolactinemia. And as people get older or have other risks, then transdermal estrogen is a safer form of estrogen in terms of minimising risk of DVTs, etc. So if we're thinking about potential complications in people that we're prescribing estrogen to, we're thinking about cardiovascular risk, arterial and venous thrombotic events risk, but also insulin resistance, gallstones, liver dysfunction, etc. And in terms of thinking about thrombotic issues, we don't really, or in fact we don't have data for trans women. In terms of that, there's no big prospective data collection. There are some smaller retrospective studies, and a recent review that looked at all those studies together was really only able to say, yes, there is higher rates of venous thromboembolism with estrogen therapy. It is higher in the first year, so that baseline risk assessment is important, and the lowest risks are with transdermal estrogen. If we're thinking about hormone maintenance for masculinizing therapies, that's testosterone. That comes in a range of forms, and in New Zealand we have patches, we have injections, depot testosterone, sustanon, Reandron. And probably one of the take-home messages is you must check for allergies to peanuts and soya for sustanon, because that's in the adjuvant for the medication and injection. And then in terms of ongoing looking after somebody that you're prescribing testosterone for, again, checking blood tests at least annually and really watching the full blood count for polycythemia. And in terms of your endpoint for estradiol and testosterone, really just looking for normal male range values. Monitoring for pregnancy risk if appropriate, and that's that thing about separating that your sexuality identity is very different from your gender identity. Once you're well on the pathway of being prescribed testosterone, you won't be ovulating, but certainly when you're initiating testosterone, or if somebody's had a break and restarting it, there would be a risk. So you need to be asking people you're prescribing for if there would be any risk in terms of sexual contacts of a pregnancy. And particularly watching for polycythemia in addition to altered lipids, mood changes, obstructive sleep apnea, and small risk of other problems. So in terms of thrombotic issues for trans men, we don't really have data at all. There's no clear increased risk, though, from the studies that have been done in terms of venous thromboembolism associated with testosterone, and there's no clear increase in cardiovascular events either. But I think that, the data we've got is what we've got. The knowledge we have is what we know at the moment, and I think that, with time, we will get more information. So really it's just watching the hematocrit, and if the hematocrit is rising, then thinking about talking to somebody about that. And the last two slides I just wanted to look at a little bit, just to let you know that at the moment currently we're going through the process of writing up the Auckland Regional Health Pathways, and they won't be up next week or the week after, but watch this space, because there will be a lot of information on the pathways to support primary care, and also some very clear ways of referring to secondary care. So I think that's going to be important when it's completed. And currently what's happening in Auckland, I spoke about the two services, but what will be happening over the next couple of years is bringing all those services together into one regional transgender health service. So I think that's very exciting, and I think there's lots of opportunities to do that really well. And finally, GP practice audits. Now, I know every year everyone has to do an audit, so this would be a really fun audit to do as a practice team. So I really encourage you to have a look at this audit. It's available on the Goodfellow, the conference site, and it has been endorsed by the College of GPs, and just looks at the whole of practice supporting gender diverse clients that you will be seeing and working with in your communities. So thank you very much.
There are mics down here if somebody wants to come down and ask a question. Do you mind if I ask the first question? I'm such a good position here. So gender reassignment surgery, because what I know about that is, I've been very interested in this field for many, many, many years. I started out before a GP as a psychologist, and I used to work in this area. So my understanding is that the guy that used to do it is retired.
Yes.
And there's nobody left to do it. Am I right?
Yes, that's correct. Yep, Peter Walker, who was in Christchurch, retired a few years ago. There are lots of different gender-affirming surgeries, and they range from, laryngeal surgery, chest reconstruction surgery for trans men, and then, of course, full gender reassignment surgery if we're thinking about bottom surgery. And some of those surgeries are available in New Zealand. In Auckland, we do have some access to chest reconstruction surgery, which is great. There is nobody currently trained in Auckland in terms of bottom surgery. So at present, the only way to access funded support through that is through the high cost treatment pool, which is a fund of money that is held by central government. The problem with that is that the high cost treatment pool was really set up to fund, rare medications for rare events or health issues. And this, of course, is not a rare event or health issue, and currently the waiting list is literally 50 years. So it's not an ethical waiting list. You can't put a young person on a waiting list where they're going to have to wait 50 years for their funded surgery. So clearly it's a system that's not working and needs to be addressed. The profession of plastic surgeons, I think they're called the APAS, have issued a statement in last year on what they see as their preferred outcome. And they see the best option for New Zealand as training someone and having someone provide services in New Zealand, rather than New Zealand paying for people to go overseas or paying for a locum surgeons to fly in and out every 6 months. And I think that's something that we're just really hopeful will happen sooner rather than later.
Could I say they train more than one, please? Any other questions? You want to go to the mic, or?
Yeah, hi. I'm Ruth, GP in South Auckland, and also Auckland Central. I recently saw a young person who they were very distressed, self-harming, 15-year-old. They've been in contact with, been seeing people from Rainbow Youth, and they were trying to get referred to, your youth health centre. And they also were under the Kari Centre because of the suicide risk. Parents were not very sort of supportive of his F2M journey. And I just wondered, what's that liaison like between the Kari Centre and Centre for Youth Health, and also how you work with Rainbow Youth and how that all works? Because this young person, sort of 4 weeks on, I saw in a letter, is still sort of waiting to be seen at Centre for Youth Health. So I just wanted to know how we can help facilitate those referrals.
Yeah, absolutely. That doesn't sound like a good situation. I would check with Centre for Youth Health, because there isn't really much of a waiting list, and 4 weeks seems like a very long time to be waiting. Normally we pick people up and see them quite quickly. We are trying desperately to forge links with the CAMS teams around Auckland and also adult mental health services, because there is a real need and gap, absolutely. We fortunately at Centre for Youth Health have a very close working relationship with Whirinaki, and we have had several meetings with Andrew Cox, who's the director of the Kāre Centre, to try and facilitate some kind of working closer together, and I think that's still a work in progress.
Yeah, I just wanted to add that that's often, in the last maybe 6 months to a year, that's become a lot of what I'm doing as a kind of liaison person, is navigating between the Kāre Centre and Centre for Youth Health or some other service. And I'm only one person part-time, so there's no other navigation kind of services that seem to be offered. That's one of the lacks, is people can't figure out not just where the service will be that will offer the health service, but how to figure out what the pathway looks like, which is why the Pathway Project is so important, to try and spell those things out more clearly. But yeah, you'd be welcome to contact me at Affinity Services for more of that link. Anything in ADHD, mental health services, I can help with. I can try and navigate or sort out. I'm not a clinician, but I have the links to try and help, yeah.
I was just wondering if there's any movement towards initiating hormone therapy or initiating puberty blockers in primary care?
Yeah, good question. And I think some GPs with an interest in this area, will be able to do that for sure. I guess one of the advantages of the youth service is we've got lots of time. Our appointments tend to be an hour to an hour and a half, and so we've got plenty of time to talk to people and get to know them and really offer some wraparound supports, and that's a little bit harder in primary care. But yeah, absolutely, we're happy to work with primary care and work out how we can do things better together, absolutely.
I did have one more question. When you were talking earlier about that there is for transmasculine people still risk of pregnancy when first starting on cross hormones, when does that, how long does somebody need to be on, and what kind of dose do they need to be on before that risk of pregnancy stops, assuming that?
Yeah, I think that's variable. I guess, one of the indications is when bleeding stops, when periods stop, and that takes a variable length of time for different people. And often when we're initiating testosterone, we're starting on quite low doses and building up. So again, it may take 6 months, it may take longer. But sometimes we're starting off with puberty blockers or something else to achieve bleeding cessation initially before we're having the conversations about starting testosterone and overlapping things. So there's lots of different ways of doing it, really.
Hi, I'm Penelope and I work in specialist mental health services in Christchurch. And I'd just like to make a comment saying, Joey, thanks about the whole thing about this contract. I think that's a really great idea. And in my experience, there's a lot of fear in mental health services and in health services in general about referring people even for hormone therapy and things. And again, down where I come from, there doesn't seem to be any clear pathways for doing that. And I've seen young people who have a lot of distress around all this, and there's so many blocks in the way of helping young people get to who they need to see. And so, I like the idea of that contract, and also I think that would alleviate a lot of professionals' distress too, and knowing about which parts are permanent, which parts aren't, how you can back off it, and helping people even to make a social transition and things. So I'll certainly take that information back with me and find that really useful, so thank you.
Yeah, you're really welcome. You can show that video anywhere you like. We just have to credit Sam Orchard and DPSN, and then it's freely available on the website all the time. I did have something I wanted to say in response to that, and now I've forgotten. Oh, it was something about Christchurch that I heard recently from one of my friends who's in Christchurch about some conversations that are happening there that are boding well for better pathways and better services, especially for young people who are gender diverse or wanting to transition or wanting access to those services. So that there is hope, and it's definitely, you know, handfuls of well-intentioned people who try and make something work out of a system that's really problematic. But I do think the more hoops you can take out of that system, you know, the more barriers. It's not fun for the provider, those kinds of barriers, because that's an intense responsibility. That's a feeling of like, oh no, it's up to me to decide if this person really is what they say they are, and what if they change their mind? They'll come back to me and say that I ruined their life. I mean, people change their mind. That happens. Humans don't always know what's going to happen later on. But if you are doing a robust informed consent process and you are talking about, like with any medication, talking about all of the risks and what's reversible and what's not, what's a likely time frame, what's realistic, you know, making sure the person doesn't think things are going to happen that aren't going to happen, or if they don't think they can pick and choose the different effects that hormones give you, because you can't really. And if they know all of that, then it should take the pressure off both sides, I would think.
Yeah, because I think that perhaps in where I work, people don't feel confident around that, so then they are waiting for months to get into secondary services, and so the young person is left in this real quandary, and people left in a quandary in how to actually support people, like, are they going to say the wrong thing, and how can we do that? And another thing I'd be interested in you commenting on is that a young person particularly that I have had some dealings with really doesn't want to get involved with other young people who are in this process. Have you got any ideas, because they are not having much support anywhere, and clearly they would benefit from some, but I just wondered, what's the most non-threatening way, do you think, that
I mean, peer groups online, like if they don't want to meet people face to face, there's a lot of online support on Facebook groups that someone could find. We don't have a lot of sustainable funding for that kind of work, and so there aren't, you know, and a lot of organisations like Rainbow Youth or others in other places outside of Auckland do run groups as a way of offering services, and if someone doesn't want to attend a group, then it's hard to know how they might access it. But I mean, I recommend a lot to my young people that we can find someone who's a counsellor or a psychologist or someone who will support them throughout the journey, and that's a matter of going on the disability allowance quite often, and, you know, getting your 10 sessions and renewing it every time. And it's a bureaucratic nightmare, like dealing with WINS usually is, but it's a way of trying to pay for counselling that's not available in the public system usually. So there are counsellors who will see people at a low cost to try and do it that way, and that's a kind of face-to-face thing that's not a peer group. Might be helpful.
Thanks.
Can I ask the technician just to put on our very last slide? We've got a slide that shows some web links and some Google searches that will take you to lots of resources. The miscellaneous website, and Joey and some...
Got some stuff on it. It's got some stuff on it.
So that includes organisations that you can refer people to, as well as patient resources. You've heard about the audit of medical practice. There's the Agenda website, which has lots of resources, lots of information, including things that are easy to find, things that are hard to find. Even the Human Rights Commission, Trans People Facts and Info here in New Zealand, a publication with Section G about health resources in particular. These are available at the desk. Take as many as you want for your clinics. They're also available for free from Mental Health Foundation, Rainbow Youth, and yeah, there is stuff. It just requires a bit more effort to find, but at least these websites and then the regional pathway will have links to the plethora as they get published.
You must forgive me, I have to bolt. I have to get my ferry, or I'm not going to get home tonight. But I'm really, really grateful that I was assigned as a moderator for this. I can't believe my good fortune, and thank you guys very much. This is an adorable gift. Stay as long as you want if you don't have to get a ferry.
Thank you. Thank you very much.
It is 5:30. I've got an Adele ticket, and I'd like to go. But we will take any questions if you want to come up. Thank you very. Yeah, sorry, we're not staying all night, so please come forward if you've got any other questions, and we'll give you our phone numbers if we need to. Okay. Thank you very much for attending. Good night.